Welcome to Prakash Med. Today we are going to talk about SLE, that is systemic lupus erythematosus. Let's look at it one by one. This is SLE. We will expand it now. Systemic lupus erythematosus. The way of studying is we need to understand these words initially only, so that when in Viva this question is asked, we can directly answer it. So, what is the meaning of systemic here? It is a multi-systemic disorder, such that it can affect several systems such as skin, CVS, blood vessels, joints, etc. So that you understood, SLE is a disorder that can affect several systems all across our body. Then we go to two words, lupus erythematosus. What is lupus? Lupus is a word that means wolf in Latin. It got SLE got the name lupus because of the fact that it has a lesion on the face that will look like wolf-eaten appearance. So it is actually given in 13th century. It is not that important. I'm just mentioning it like that. Then around 19th century, erythematosus, the word was added. That's a Greek word. It means reddish character. Reddish. It has a reddish character. That's what it means. So we understood the word SLE directly. Now we go to the definition. So this is the definition. SLE is an autoimmune disease involving multiple organs. So when we get SLE as a question, it can be asked as 15-mark question or 6-mark question. We have to write according to this. Like we have to write about definition. If you write about the points that I mentioned earlier, it will be a plus marks. So if you write definition like this, it's an autoimmune disease involving multiple organs, and then it is characterized by broad spectrum of autoantibodies such as anti-nuclear antibodies, etc. And the cause of injury here is deposition of immune complex and binding of antibodies to various cells and tissues. Like this is directly copied from Robbins, and you will not understand it right now. You will understand by the end of the video. I will make sure of that. We will explain it each and every single point detail. Let's talk about etiology. So when you think of etiology, you should think only one word, that is cause. What is the cause of SLE? There are three causes. One is genetic causes, second is environmental, and third one is immunological. So let's talk about the genetic causes. We can divide it into first one as familial association. What familial association means is nothing but SLE runs in families. That is, if your brother has SLE or if your mother has SLE, like it runs in families. That's all you need to remember about that. And there is higher risk of SLE in monozygotic twins, dizygotic twins, etc. Then second factor of genetic, loss of complement components. Loss of complement components. What is the function of complements? They will remove immune complexes from our body. So when complements are not functioning properly, immune complexes will deposit in different parts of the body, and that exactly is what happening in SLE. And the third one is major histocompatibility related, that is HLA, DR2 and DR3. HLA-DR is a type 2 major histocompatibility complex. That is, it is a type of complex that is present on antigen presenting cells, which will present the antigen to the T cell. But in this case, when these variants are present, DR2, DR3 variants are present, they will lose self-tolerance and present self-nuclear antigens. So what happens is, body will think our own antigens as enemies and attacks it on. Now we go to the environmental causes. Environmental causes are actually very easy. Most of the etiology disease in pathology, most of the etiology has environmental etiology is basically UV radiation, cigarette smoking, female, sex, etc. In reproductive age, there is a higher chance of SLE. And there is one more thing here that I will mention now as a second point, that is drug related or drug associated SLEs. That is drug associated SLEs. There are some drugs such as hydralazine, procainamide, isoniazid, etc. Usage of these drugs will cause, in some people, if they have genetic background, usage of these drugs will cause SLE like symptoms. Withdrawal of this drug will remove it completely. Hydralazine is a drug that is usually used for antihypertension, and isoniazid is used as an anti-tubercular drug, and procainamide is an anti-arrhythmic drug. It can be asked as a 3-mark question like or MCQ. Hydralazine, procainamide, isoniazid, etc. are the drugs that cause SLE-like symptoms. Then there is immunological cause. So, what are the immunological causes? Number 1 is failure of B cell tolerance, which means nothing that B cell will think our body as the enemy. So what happens? It will send signals to destroy our own body. Just think simply only. And the second point is toll-like receptors and interferons. We will learn about more in pathogenesis. Go to pathogenesis. Pathogenesis is actually simple. It is just the exaggerated version of etiology itself. So, as I said earlier, susceptibility genes are there, such as HLA, DR2 or DR3, which will cause loss of self-tolerance, and there are B and T cells will be in this condition, which already lost self-tolerance, and simultaneously there is this condition whereas external triggers happen, such as UV radiation, and it will cause apoptosis, and there is defective clear of apoptotic bodies, which will increase the burden of nuclear antigens. This diagram is directly taken from Robin, so if you draw it in the exam, teachers will be impressed and you will get extra marks. So try to draw diagrams maximum from Robins. So when the increased burden of nuclear antigens comes and it will bind to the anti-nuclear antibody, antigen-antibody complexes are formed here. It's anti-nuclear antibody, antigen-antibody complexes are formed here. These antigen-antibody complexes are endocytosed by the B cell and dendritic cells. So, and it after the endocytosis, it will get engaged with the TLR, that is the toll-like receptor. We talked about it earlier. What happens here is TLR is the reason for the entire thing. We will think like that because toll-like receptor think these antigen-antibody complexes as our enemies, like external antigens. They will treat like that. So because of that, TLR stimulation of B cell and dendritic cells occur, and it will lead to producing higher number of anti-nuclear antibodies. So what happens here is anti-nuclear antibody, antigen antibody complex is formed initially, then it is endocytosis happens and TLR get activated, which will cause the activation of the B cell and T cell. Here as you can see, interferons will play a major role. It is a cytokine that is usually seen in antiviral conditions. It is also get released by the B cells and dendritic cells, and it will simultaneously activate, and it will also lead to the persistent high level anti-nuclear IgG antibody production. What happens is at the end we will have a high number of anti-nuclear antibodies. We will have to write pathogenesis mostly in a flowchart, then only you will get marks. So I added a flowchart in the next slide. So let's see this. First step is increased apoptosis. Then there is impaired clearance of apoptotic bodies are there. Then there is accumulation of increased amount of nuclear antigens are there. And anti-nuclear antibodies are produced simultaneously from the B cells and T cells which already lost self-tolerance. Then there is formation of antigen antibody complex which will undergo circulation. This is endocytosis by B cell and T cell, and TLR get engaged here. And TLR stimulation of B cell and T cell by interferon alpha causes persistent production of IgG and autoantibodies. So the question is, how does autoantibodies causes tissue injury? It causes tissue injury by two mechanisms, that is type 3 hypersensitivity and type 2 hypersensitivity. So this is the type 3 and type 2 hypersensitivity. You will learn it separately anyway. I'm just mentioning it. Type 3 hypersensitivity. It occurs with the deposition of immune complex. It is the most common cause of tissue injury and visceral lesions. And the type 2 hypersensitivity. Autoantibodies against cell surface antigens specific for RBC, WBC, platelet. These opsonize these cells and promote their phagocytosis. This is correct. Yeah, phagocytosis up to here. Spelling is okay. And that's all about pathogenesis. We will learn more about autoantibodies in the next slide. Autoantibodies is actually a previous year question, so we need to remember it. It was a 3-mark question, but it can be asked as 6-mark question as well. So, what are the autoantibodies present in systemic lupus erythematosus? There are 3 autoantibodies specifically. First one is anti-nuclear antibodies. Second one is antibodies against blood cells. And third one is antiphospholipid antibodies. So, as we mentioned earlier, anti-nuclear antibodies is the most important antibodies present in the autoantibody section, or these are the major antibodies that will cause SLE. So, these are the type of anti-nuclear antibodies I mentioned here. First one, anti-double-stranded DNA antibody, anti-Smith antibody, anti-histone antibody, antibody to DNA, etc. are there. The first two ones, anti-double-stranded DNA and anti-Smith antibody. These both antibodies are quite important because these are specific to SLE. These clinical utilities we will study later in the laboratory diagnosis, so no need to worry now. Anti-Smith antibodies are specific for SLE and stuff like that. Then second part is antibodies against blood cells. See, I mentioned earlier now, antigens are present in the RBC and all other blood cells. So antibodies will act against these blood cells and destroy it, which will cause several conditions like hypothrombocytopenia, etc. Thrombocytopenia, etc. And there is antiphospholipid antibodies. These are the 3 types of antiphospholipid antibodies. First one is lupus anticoagulant antibody, anti-cardiolipin antibody, and anti-beta-2 glycoprotein antibody. There's a question here, like sometimes in SLE patients, syphilis is considered positive because anti-cardiolipin antibody is used in syphilis as well. So sometimes syphilis is seen positive in SLE, but it is a false positive. So let's go to the next part. LE bodies. So what is LA bodies? As I mentioned earlier, anti-nuclear antibodies are there, right? Anti-nuclear antibodies. These are antibodies specific to nuclear part like histones, DNA, etc. So basically these are inside the cell. So and ANA cannot penetrate intact cell. But if nuclei of the cells are exposed, they can bind to them. So that is the whole concept here. In tissues, nuclei of the damaged cells react with antinuclear antibodies and forms LE bodies. So what we here seeing is a LE cell actually. So if LE bodies are present in our body, obviously our phagocytic cells will intake it and it will be seen as LE cells. So how do so if you take a blood sample and it is agitated, take a blood sample like this and it is agitated, there will be damage to the nucleated cells. Nucleated cells will be damaged, which will expose the nuclear content outside and it will cause the formation of LE bodies and phagocytes will intake it and forms LE cells. If a question on ANA comes, that is antinuclear antibody comes, you can mention LE bodies and LE cells as well. This diagram can be used. It is from Pathology Made Simple. So let's talk about the morphology part. In writing, whenever you write pathology exam, morphology part is the most important part. So as you can see, morphology in SLE is extremely variable. So that is the first point. When you write morphology, you have to mention this point, very important. Morphology in SLE is extremely variable and most characteristic lesions are due to the deposition of immune complex in blood vessel, kidney, connective tissue, skin, etc. Now the point is you have to mention each one and explain each one maximum clearly. So we will go to the first section, that is kidney. Kidney, as you can see, has six pattern of glomerular diseases. Kidney is actually involved in around 50% of SLE patients, and it is one of the most important organs involved in SLE. These immune complexes deposited in different part of the kidney, and it will cause these disorders. So this morphological classification of lupus nephritis is given here. I will mention that also. Morphologic classification lupus nephritis. If you ask me if it is important or not, I mean they can ask a 6-mark question if they want to make the exam difficult. At least you should know the name of these disorders, such as minimal mesangial, mesangial proliferative, focal lupus, diffuse lupus, membranous lupus, and advanced sclerosing. So first one is minimal mesangial, and there is no light microscopical changes. And mesangial proliferative is mesangial cell proliferation. You can write like that. And focal lupus nephritis, it is less than 50% of the glomerular involvement is there. And diffuse lupus, more than 50% involvement is there. Such points are there. If you write like this, you will get more marks. It is an important point. Kidney 6-mark questions have been asked in previous year questions. Now we will go to the next organ. Blood vessels. In blood vessel, what is happening is acute necrotizing vasculitis. Acute necrotizing vasculitis happen because of the deposition of immune complexes in the blood vessel, and it will cause fibrinoid necrosis. And it will cause narrowing of the lumen. Narrowing of the lumen causes several disorders, like think if blood vessel, this disorder is happening in brain, it can go to convulsions or even headaches. Like the basic symptom headache even can be a symptom of SLE. And then we will talk about heart. In heart, any layer can be involved. The keyword you need to remember here is Lippmann sac endocarditis. It is one of the most favorite MCQ question of the examiners. Lippmann sac endocarditis is the characteristic feature of SLE. That is basically endocarditis. It is a non-bacteriological endocarditis. Non-bacteriological endocarditis only. You know the most common cause of endocarditis is Staph aureus. Now we will go to the skin part. As I mentioned already, erythema is the feature. Erythema that spread across cheek and nasal bridge is present, and this erythema accentuates on exposure with sunlight. That is, photosensitivity is the characteristic feature of the disorder. Photosensitivity. That is an important point because in the exams there will be a case mentioned, and photosensitivity you can see it always. And then there is, it is not on face only actually, you can actually see on trunk and extremities as well, and the joints part. Synovitis is seen, and it is rarely seen, like it will cause minor deformities only. Now we go to the next part. So clinical features. As I mentioned earlier, SLE is a multi-system disorder. And it has variable clinical presentation. So what are the clinical presentations that we see in SLE? One, butterfly rash. Whenever you hear the word butterfly rash, think of nothing else, it is SLE. Butterfly rash over the face. Second one is fever. Third one is pain without deformity in joints. That is because of the synovitis I already mentioned, and the SLE patients are susceptible to infections as well. So these are the major clinical features, and it will show a variety of clinical features as well, but these are the most visible clinical features we can see. Then we will go to the lab findings. So lab findings. We do actually immunofluorescence assay or ELISA or multiplex flow cytometry, etc. to identify the autoantibodies. Identifying the autoantibodies is the key in identifying SLE, because I already mentioned anti-double stranded DNA antibody, anti-Smith antibody. Such type of antibodies are key elements in SLE only. So if you can identify those autoantibodies in here, we can directly say it is SLE only. Then we will see about other conditions such as blood analysis. On blood analysis, we will see thrombocytopenia, increased ESR. On urine analysis, anemia as well. Urine analysis, we will see hematuria, proteinuria, etc. I mean, hematuria and proteinuria is caused by the attack of immune complexes in the kidney. These are the major laboratory findings we can see, and decreased complement levels are also seen, like I mentioned it in the genetic conditions, right? So it is also seen as laboratory findings. Then we will go to the next part. These are some PYQs. Okay, so we will just read it out. It is okay. We will read one first question. A 30-year-old female. I already mentioned female has more susceptibility to this condition, complaining of fever, butterfly rash on the face, pain in the joint, chest pain because endocarditis I mentioned, and having photosensitivity. All the keywords are here. So simple. What is the professional diagnosis? As simple as that, it is SLE. Etiopathogenesis we already mentioned, etiology we mentioned, and pathogenesis we mentioned. Make sure you draw the diagram that is mentioned in Robbins so that we will fetch maximum mark. And the specific diagnosis criteria. That is actually not mentioned in all textbooks, but I will mention it in last just as an additional info. It is mostly not asked in PYQs. It is this PYQ is not actually KNRHS PYQ. It is from Kerala Medical Colleges. It is actually a difficult question. So specific diagnosis criteria I will just add at the end note. If you want to read it, you can read it. And see, describe the morphology of kidney disease. See, the question comes like this. All the six classifications have to be mentioned here and explained. So if a question comes like this, you have to explain all of it. That is why you need to know about all the six classifications. This question is a very short answer, like 3-mark question. This is a KNRHS question. Autoantibodies in systemic lupus erythematosus. You can mention the name of the autoantibodies: antinuclear antibody, antiphospholipid antibody, antibodies against red blood cells, etc. We can explain like that, simple only. Then we will see these questions as well. A 55-year-old woman again, 2-year history of joint pain, photosensitivity, rash in a sun-exposed distribution. I mentioned sun exposure causes the accentuation of the erythema. Urine examination showed proteinuria because kidney damage. Immunology profile done showed high titers of antinuclear antibody. Presence of ANA is characteristic of SLE. What is your probable diagnosis? You know what is it. Explain the patient's renal disease that we mentioned earlier. It is an important question in morphology. What are the blood vessel changes expected in this disease? I mentioned earlier. Necrotizing vasculitis is seen here. And then there is one more question for 3 marks. What are wire loop lesion? How can they be demonstrated? I didn't mention it properly, but as you can see, wait a second. In diffuse lupus nephritis class 4, we can see wire loop lesions, that is circumferential thickening of the capillary wall forming wire loop. What I'm saying is, knowing about the morphology is quite important in pathology. Pathology is actually morphology only, that is gross and microscopy. You need to know everything about it. So these are some previous year questions and everything. This is the revised diagnostic criteria, just adding it. A patient is classified as having SLE if 4 of the clinical and immunology criteria are present at any time. It should not be concurrently, but it should include at least 1 clinical and 1 immunology criteria, that is cutaneous lupus, alopecia, antinuclear antibody, everything I mentioned already. But this is the diagnostic criteria. It is not as important as Jones criteria or something like that. If you want to know more, you can just read it. I will add it in the slide. So that's all for today. I believe you have understood almost all the topics of systemic lupus erythematosus. Thank you all.